Frozen shoulder, also known as adhesive capsulitis, is a common and often debilitating condition that causes pain and stiffness in the shoulder joint. The exact cause and pathophysiology of this condition are still unclear, but several risk factors and mechanisms have been suggested. In this video, we will review the latest evidence on the epidemiology, diagnosis, treatment, and prevention of frozen shoulder, and highlight some of the new discoveries and challenges in this field. Epidemiology. Frozen shoulder affects 2 to 5% of the general population, with a peak incidence in the 5th decade of life. It is more common in women than men, and in people with diabetes, thyroid disease, Dupuytren syndrome, nephrolithiasis, cancer, Parkinson's disease, shoulder injury, smoking, heart and neck surgery, or chronic regional pain syndrome. Comorbidities occur in 85% of patients with frozen shoulder, and 37.5% have more than 3 comorbidities. Frozen shoulder can also affect other joints such as the hip, wrist, and ankle, but less frequently. Diagnosis. Frozen shoulder is diagnosed based on clinical features and physical examination. The condition typically presents with 3 stages: freezing, painful, frozen, stiff, and thawing, recovery. The main feature is a progressive limitation of both active and passive range of motion, ROM, in the shoulder, especially in external rotation. The duration of each stage can vary from months to years, and some patients may have residual pain or functional impairment. Imaging modalities such as fluoroscopy, ultrasound, and MRI can help to rule out other causes of shoulder pain and stiffness, and to identify characteristic findings of frozen shoulder, such as capsular thickening and fibrosis, reduced joint volume, ligamentous hypertrophy, synovial inflammation, and fat obliteration. Treatment. The treatment of frozen shoulder aims to reduce pain and improve ROM and function. The most commonly used intervention is physiotherapy, which can include exercises, mobilization techniques, modalities, and education. Physiotherapy can be supplemented by intra-articular steroid injections, which can provide short-term pain relief and improve ROM. Other treatments that can be offered in secondary care include joint manipulation under anesthesia, arthroscopic capsular release, and hydrodilatation. However, none of these interventions have been shown to be clinically superior to physiotherapy and steroid injections in the largest randomized controlled trial to date, the UK FROST trial. Therefore, the choice of treatment should be based on patient preference, availability of resources, and potential risks and benefits. Prevention. The prevention of frozen shoulder is not well established, but some possible strategies include early detection and treatment of risk factors, such as diabetes and thyroid disease, avoiding prolonged immobilization or overuse of the shoulder joint, maintaining a healthy lifestyle, such as quitting smoking and exercising regularly, and seeking medical attention if shoulder pain or stiffness persists or worsens. Further research is needed to identify effective preventive measures for frozen shoulder. Radiology and imaging analysis play a crucial role in evaluating frozen shoulder, also known as adhesive capsulitis. Several imaging modalities can aid in diagnosing and assessing the condition. Here are some commonly used techniques. 1. X-ray. X-rays are often the initial imaging modality used to rule out other possible causes of shoulder pain, such as fractures or arthritis. While they may not directly show the soft tissues or the extent of adhesive capsulitis, they can help identify any associated bone abnormalities or joint space narrowing. 2. Magnetic resonance imaging, MRI. MRI provides detailed images of the soft tissues, including tendons, ligaments, muscles, and the joint capsule. It can help evaluate the thickness and integrity of the joint capsule, detect inflammation, and assess the presence of other conditions that may contribute to shoulder pain or restricted movement. 3. Magnetic resonance arthrography, MRA. MRA involves injecting a contrast agent into the shoulder joint before performing an MRI scan. This technique enhances the visualization of the joint capsule, allowing for better assessment of any thickening, contracture, or adhesions. 4. Ultrasound. Ultrasound is a dynamic imaging technique that can evaluate the shoulder joint in real time. It is particularly useful in assessing the movement of tendons, detecting inflammation, and identifying any associated bursitis or rotator cuff abnormalities. Ultrasound-guided interventions, such as corticosteroid injections, can also be performed to alleviate symptoms. 5. Computed tomography, CT, scan. CT scans provide detailed images of the bony structures and can help assess any bone abnormalities, osteophytes, or calcifications in the shoulder joint. While CT scans are not typically the first choice for evaluating adhesive capsulitis, they may be considered in specific cases or when surgical planning is necessary. It is important to note that while these imaging techniques can aid in the diagnosis and evaluation of frozen shoulder, the diagnosis is primarily based on clinical examination and the patient's symptoms. Radiology and imaging studies are often used to support the clinical assessment and rule out other potential causes of shoulder pain and restricted range of motion. A skilled radiologist or orthopedic specialist should interpret the imaging findings in the context of the patient's overall presentation. New advances and challenges. Frozen shoulder, or adhesive capsulitis, is a common condition that causes pain and stiffness in the shoulder joint. It can affect up to 5% of the population, especially women, people with diabetes, thyroid disease, and other comorbidities. The diagnosis and management of frozen shoulder can be challenging, as the condition has a variable course and response to treatment. Radiology and imaging play an important role in ruling out other causes of shoulder pain and stiffness, identifying the characteristic features of frozen shoulder, and monitoring the progress and outcome of treatment. In this video, we will review some of the recent advances and challenges in radiology and imaging of frozen shoulder, and highlight some of the emerging trends and technologies in this field. Recent advances. One recent advance is the use of MRI to correlate clinical features and imaging findings in early frozen shoulder. A study by Choi et al. 2020 investigated the association between ROM, pain, symptom duration, and MRI measurements of capsular thickness and hyperintensity in 29 patients with early frozen shoulder. The authors found that maximal axillary and humeral capsular thickness measured on MRI were negatively correlated with ROM for internal rotation. Also, hyperintensity in axillary recess and glenoid capsule were correlated with ROM for abduction. Humeral capsular hyperintensity was correlated with ROM for forward flexion and symptom duration. These findings suggest that MRI can provide useful information for assessing the severity and prognosis of frozen shoulder. Challenges. One of the challenges in radiology and imaging of frozen shoulder is the lack of clear guidelines on the optimal use and timing of imaging modalities. Currently, there is no consensus on whether routine X-rays are necessary for suspected frozen shoulder, or whether ultrasound, MRI, or Mr. arthrography are superior for diagnosis and evaluation. A retrospective study by Roberts et al. 2019 reviewed 350 X-rays performed for patients with a provisional diagnosis of frozen shoulder and found that only 2.3%, had masquerading pathology that could affect management. The authors concluded that routine X-rays for suspected frozen shoulder offer little overdiagnosis based on history and clinical examination alone. Another challenge is the limited evidence on the effectiveness of different treatment options for frozen shoulder and their impact on imaging outcomes. Although various treatments such as physiotherapy, steroid injections, manipulation under anesthesia, arthroscopic capsular release, and hydrodilatation have been proposed for frozen shoulder, none have been shown to be clinically superior in randomized controlled trials. The UK Frost trial, 2022, which compared these interventions with early structured physiotherapy and intra-articular corticosteroid injections in 503 patients with frozen shoulder, found no significant differences in pain or function at 12 months. Moreover, there is a lack of studies on how these treatments affect imaging findings such as capsular thickness, hyperintensity, joint volume, or ligamentous hypertrophy. Emerging trends and technologies. One of the emerging trends in radiology and imaging of frozen shoulder is the use of novel imaging techniques or biomarkers to improve diagnosis and prognosis. For example, a study by Janssen et al. 2023 used MRI features to identify MYCN-amplified RB1 wild-type retinoblastoma, a rare subtype of retinoblastoma that can mimic frozen shoulder. The authors found that this subtype had distinctive MRI features such as diffuse enhancement without calcification or necrosis, intratumoral cysts or hemorrhage, optic nerve invasion or extension beyond the orbit. These features could help to differentiate this subtype from frozen shoulder or other masquerading pathologies.